Everyone for joining today, our special edition of the CPC seminar series, and we're very excited to have Dr. Linda Cook here to present her research. Just a couple of other updates for folks. A reminder that our next monthly presentation will be Dr. Lisa Carter-Harris, a colleague and friend who studies lung cancer stigma and lung cancer screening. She is an associate attending at the Memorial Sloan Kettering Cancer Center in Manhattan, and we look forward to her comments and joining us. And I'll go ahead and proceed with introducing Dr. Linda Cook. Dr. Cook is currently the interim chief and professor in epidemiology, biostatistics, and epidemiology at University of New Mexico School of Medicine, and appropriately, she is the co-leader of the Cancer Prevention and Control and Population Sciences group at the University of New Mexico Comprehensive Cancer Center. Dr. Cook initially started her training at the wonderful institution at the University of Iowa before completing her master's and doctoral degrees in epidemiology at the University of Washington, completing a postdoc in epidemiology. And her work has really focused on ovarian cancer, but also extends to endometrial and breast cancer research. She is a really well-funded and highly respected investigator in this space, and we're really excited that she is a finalist for our position as Associate Director of Population Sciences at the University of Colorado Cancer Center. And without further comment, I'd like to introduce Dr. Linda Cook.
Thank you, Jamie. That was very nice. That was a lovely introduction. I'm really happy to be here today. I wish it was in person, but we all know that that's not happening in the day and age that we live in. I'm going to wear a headset because I noticed that it was very informative when we were going for our Cancer Center renewal, and we kept recording our presentations. And I realized I move my head a lot when I give a presentation, and so what happens is that my voice comes in and out. So for your benefit of being able to hear me, I'm wearing a headset, but if anybody can't hear me at any time, just please let me know. So I put together a slide presentation for ovarian cancer, and I realized it was just way too long. I swear I could talk for 4 hours on ovarian cancer. Clearly you don't want to hear a 4-hour talk, and I don't think I want to give a 4-hour talk. So what I decided to do was to talk about, to really give you an overview of ovarian cancer, talk about some of the major achievements that have been made with ovarian cancer, and then some of the future challenges that might be associated with them. And I'm just going to focus on 3 topics. One's the incidence, mortality, and survival. The other is subtype classification, and the other is risk factors. And so this is going to be a very broad overview, although I still have a lot to say, and I'll keep trying to move through this very quickly. So incidence, mortality, and survival. So this is the good news story. So what we have here is data that I've just pulled off of the SEER registry. On the right panel, we have Black women, and on the left is white. This is showing both incidence and mortality. Incidence is in the red, mortality is in the black. And so this is a fantastic success story. Over the last 42 years, the incidence of ovarian cancer has decreased, as has the mortality, although it looks like there's a little bit of a lag in seeing any sort of mortality reduction in Black women until about 2000 for reasons that are unclear to me. Another thing to notice about this graph is that, or these graphs, is that the y-axis only goes from 0 to 20 per 100,000. So this is a rare cancer, but incidence and mortality are fairly similar. So this should just tell everybody that almost all of these women are dying of their ovarian cancer because the incidence and mortality lines are so close together. So this is just fantastic. I'm not sure from like a public health impact that we've done really anything to reduce this incidence. I think it's just happened, probably from hormone contraception, and I'll talk about that a little bit later. So now can you guys see my pointer? Yes, all right. So now what I'm going to do, this data goes back to 1975, and it's just using the 9 SEER registries. And really, the only contrast I could make was between whites and blacks. But now I'm gonna look at the incidence in these later years from 2000 to 2017 for both whites and blacks and Hispanics, because I can do that easily in SEER. So I'm going to show you 3 graphs, and these are going to be by age for the 3 racial ethnic groups. So here's the first one, and so it's a little messy, but you got to follow the lines. So the blue line here is for non-Hispanic whites, the brown line is for Hispanics, and the purple line, purplish line, is for blacks. And this is ages 15 to 39. And what you can see is that this is a little concerning, that while we see this continued decrease like we saw in the, overall graph for non-Hispanic whites, we're not seeing it for the Hispanics or the blacks. If we go to the next age group, which is 40 to 64, pretty much for the Hispanics and the blacks, again, these lines are they're flat. They're no different than 0 according to the SEER analysis, but we still see this nice decrease in incidence amongst non-Hispanic whites. And then it isn't until we get to women 65 years of age or older that you see a decrease in all of these groups, and a particularly strong decrease in the non-Hispanic whites. So, the epidemiologists on the call will their mind would probably go to, well, this deserves a birth cohort analysis because we probably have changing exposures over time. I think that's really true. I would love to do that. Anybody who would like to work with me on that, I would be happy to work with you. But I do find this is something I've been keeping track of for a while, and we see it in New Mexico as well, because we have, in the Hispanics, we don't have a very large African-American population here. And so I do find this very, very concerning. And it's something for some future research. Now I'm going to jump to survival. And so this is another good news story. Maybe survival, because we haven't seen the same mortality decrease that we've seen with incidence. So, maybe survival could be better, but we have seen some improvements, and I think that this is fantastic for the ovarian cancer cases. I'm not sure I believe this increase in the blacks, because if you took this very last point and say put it right there, you'd have a very, very flat line. So I'm not sure. We need another year of data or two to really see what's going on in the black women. But, I take this as a very positive sign. However, let's be clear that over a 17-year period, this is less than 10% improvement in survival in both groups. And really, people interpret this as the treatments that are given for ovarian cancer right now, they actually delay remission or recurrence of the disease. So what happens is that we're just pushing off the mortality, and ultimately almost all of these women die of chemo-resistant recurrent disease. So there's a lot of work that can be done there. So in my own research, I have actually gotten into ovarian cancer survival, and we're looking at a drug, ketorolac. The non-clinicians may not know what ketorolac is, but it's an NSAID. It's used for the short-term management of pain. It's commonly given after surgeries or in emergency rooms when people go in. And the reason that ketorolac even came on my radar screen is that I have some colleagues here at the University of New Mexico who are doing these drug screens, taking to repurpose drugs that were already on the market. And ketorolac came up as inhibiting cell proliferation, migration, and adhesion, with some other drugs that would inhibit RAC1 and CDC42 GTPase activation. So Tudor Oprea and Larry Sklar, who had started this, then collaborated with some basic scientists, Angela Wandinger-Ness and Lori Hudson, and they realized that this drug, ketorolac, this NSAID, had enantiomers, an R and an S enantiomer. Those of you who may or may not remember your biochemistry, it means that they're mirror images of each other. So in a stereochemistry respect, they bind to different receptors. And it turns out that the S-ketorolac was anti-inflammatory, had the COX-1 and COX-2 inhibition that you would expect of any NSAID, whereas the R-ketorolac was this one who was the one that had cancer-reducing properties, which was really, really interesting. So why would we expect ketorolac to be related to ovarian cancer survival? Well, by the time my colleagues had done this and had identified it, there was published literature indicating that there was better survival for breast, lung, and kidney cancer patients who had received ketorolac. My colleague, Carolyn Muller, here, who is a gynecologic oncologist, had also shown that IV ketorolac distributes to the peritoneal cavity, and surprisingly, it is enhanced for the R, which is the anti-tumor form, than the S, or the anti-inflammatory form. We also did, my colleagues did a number of laboratory assays and animal studies showing that RAC1 CDC42 overexpression or hyperactivation occurred in ovarian cancer, and we did an analysis off the TCGA data and also showed it through the TCGA data and showed for those that were expressed, they had a better survival. So I did a pilot study here in Albuquerque because at that time we didn't even know if ketorolac was being used in ovarian cancer surgeries. So I did this pilot study. It was kind of a quick and dirty. I regretted that later because then I wanted a lot more information than I got from this pilot study. But what we did find was that regardless of the stage of cancer, regardless of the age group, regardless of whether or not these women got neoadjuvant therapy or not, we saw a substantial survival benefit associated with receiving ketorolac. So we use this as preliminary data to submit a grant with the global hypothesis that we think that ovarian cancer patients given ketorolac perioperatively will have a better survival than those not given ketorolac. This project is fascinating from a number of different perspectives. We are literally hypothesizing that there's this window of opportunity, right after the ovarian cancer surgery to have an impact on long-term survival. And there's all sorts of other neat things, like we have we're coming up with prognostic scores and all sorts of things, and we're doing IHC. Unfortunately, this was funded on February 14th, 2020. Not unfortunately, fortunately, it was funded on February 14th, 2020, and we all know what happened by the end of February 2020. So it's been off to a slow start. We had to kind of reorganize this, and we actually did get some great work done last year. But I would be happy at some point to come back and tell you the results, because I think this will be very, very interesting. So quickly, just to kind of summarize what I think are the challenges that, some challenges that are facing us is that, despite the steady decrease in overall incidence and mortality, especially that we see in the non-Hispanic white women, we have some concerning trends in the other racial ethnic groups, especially among women 65 years of age. And I am certainly interested in pursuing this and looking at this further. And although we've had advances in treatment for ovarian cancer, I mean, there's been lots of great advances. The cytoreduction surgeries, the taxanes that came out in the late 90s, the PARP inhibitors, it just goes on. There's really a nice group of drugs now that can treat ovarian cancer, but still what this does, it prolongs disease remission. And so most of these women are still dying of their chemo-resistant recurrent disease. So we need other approaches. Certainly a lot of people are looking at targeted treatment, and hopefully ketorolac can contribute to this as well. And the big elephant in the room is, of course, that we don't have a good screening test for ovarian cancer. And, you know, if we could just shift that stage distribution to an earlier stage, that would dramatically improve survival right there without any, you know, increased, advances in therapy. So clearly a lot of people are working on that, but we're not there yet. And I'm not sure we're even close at this point to come up with a screening test that really could be used broadly in the population. So now I'd like to jump to the ovarian cancer subtype classification. And this, of course, has implications for both risk factors and for treatment of ovarian cancer. So there's really 5 major histotypes of invasive epithelial ovarian cancer. So I'm gonna take a second to tell you some about histology and pathology. And this is probably off topic for a lot of you, but when I was showing you those other graphs of ovarian cancer has 3 major types: the epithelial ovarian cancer, which is upwards of 95% of all ovarian cancers. Then there's germ cell tumors, teratomas, which I think a lot of people have heard about, quite interesting little tumors because they grow, they come from the germ cells, so they grow hair and teeth and bone, and they're interesting little tumors. And then there's the stromal cell tumors, but most ovarian tumors are the epithelial ovarian cancer tumors. So the histotypes become really important. And I have worked with my long-term collaborator at the University of Calgary, Martin Coble, who's a pathologist, and we used my OVO-BC study to validate a calculator of ovarian cancer subtype probability, and he called this the CUSP version 3 program. So I'm going to tell you a little bit about that, but I also want to point out from this table that I've shown that we are talking about ovarian cancer, right? So you might think, oh, ovarian cancers arise in the ovary. Well, no, that's not so clear. And in fact, they could arise from a number of different tissues of origin. Most people believe these days that the high-grade serous actually arises from the fallopian tube, not the ovary itself. Not clear for the low-grade serous. Mucinous appears to be the only tumor that literally arises from the ovary. And then the endometrioid and the clear cell tumors probably arise from the endometrium in the uterus. So, this is great that people really started figuring out. So this is a success that people have really started figuring out what the tissue of origin for these different tissue types of cancer are. However, there's still a lot of questions, and we still really don't know. So this is another active area of research. So, we were interested in classifying these tumors. And so in the OVO-BC study, in my study, we had the cancer registry histology, which I've shown here on the right. And this is a Sankey diagram. I'm sure everybody has seen Sankey diagrams, and I just love these diagrams showing how the classification changes. And in the middle is a single pathologist review. And at the right, there is an integrated histotype that includes all those IHC markers plus the pathologist review. And there's really 2 things to note about this, in that it's really hard to classify these tumors. I mean, we spent a lot of time doing this, and you can see all the lines going this way and that way. Also, the cancer registries at the time of my study were not distinguishing high-grade serous from low-grade serous, and so there was this big chunk of not otherwise specified tumors. Most of those became high-grade serous and endometrioid carcinomas. upon re-review. And then I would also just like to point out that I'm talking a lot about these changes and these things are moving around. You know, this misclassification probably contributes to, you know, differences in predictive survival probabilities. It probably interferes with coming up with really good risk estimates for the subtypes because, you know, they're changing a lot. But really, at the end of the day, you know, cancer registry data from, you know, whatever pathologist, wherever, to this very, you know, detailed integrated histotype, it was actually pretty close, right? It's not bad. You know, it's not bad what you can pull off of cancer registries. So this also kind of validated the use of the cancer registries. So what does this mean in terms of the survival curves? So again, I'll try to go through this quickly because this is probably of most importance to clinicians and not necessarily epidemiologists, but this is important to some of the research I do. These are survival curves. This is 5,000 days on the x-axis. We have a lot of follow-up. This is over 13 and a half years of follow-up on these women. So I've put this black bar here, which just shows you the 5-year survival, which is what people generally use as a benchmark. And so you can see that as the serous has the worst survival, and then we have the clear cell carcinoma, then we have the mucinous, and then we have the endometrioid. And you can see for a 5-year survival, these are very well distinguished, right? But then when we look at the same curves by this consolidated or integrated histotype that also uses the IHC markers, things look a little different. So now this bottom line with the worst survival is the high-grade serous, but the low-grade serous is clearly distinguishable from the high-grade serous, which here they were combined. And the one that I really want to point out here is the mucinous. You know, it was thought there for a while that mucinous had a pretty bad survival relative to the endometrioid. But what we've shown and what other people have shown is they're really about the same. The problem with the mucinous tumors is that you can get metastatic cancer from the colon or from what is called peritoneal tumors, and they look a lot like ovarian mucinous tumors. So you got to clean those out. And when you do that, you know, those two really have the same 5-year survival. And these two have the same, the low-grade serous and the clear cell really, you know, there's no difference in survival at 5 years. So this has been good to do this. So this is another success where we could, and almost everyone sees this now. So this is a real contribution to kind of cleaning up what these survival probabilities are. So again, the challenges here, we have, you know, consistent classification remains a challenge as well as understanding the source of the cancer. That might be it surprises me every time I say that. That might be surprising to everyone else as well. But that's the way it is with ovarian cancer. And then, you know, this immunohistochemical staining that we did, while it was useful in that classification, you know, it doesn't have a high enough sensitivity or specificity for a single histotype. So I think what people are thinking now is that because you can get errors in the IHC because of truncating or slice site mutations that show normal wild type staining, and this is particularly true for TP53, people are thinking of layering on DNA and RNA because this may improve classification further. So I just wanted to point out that the Ovarian Cancer Association Consortium, which is an international consortium of ovarian cancer researchers, which I am part of, and the Oval BC study is part of, they used the same technique that had, for high-grade serous cancer. So they've taken just the high-grade serous cancers, and now they're going to try to get subtypes of the high-grade serous cancer. And they did this in the same way they did this with breast cancer years ago, that they came up with these intrinsic breast cancer subtypes. This would be the luminal A, the luminal B, the HER2 overexpressing, and the triple negative. And so they've come up with 4 of these subtypes, and they've actually come up with a classifier that can be used clinically and such. So I think we're going to see even more of these subtypes, and this too could help improve both risk prediction and risk factors for these different subtypes, as well as survival and treatments that could help specific subtypes. So now I'm going to jump into risk factors. This is like a 30,000 foot overview, so I'm going to go through this pretty quickly. So genetics is clearly involved in as a risk factor for ovarian cancer. At one end of the scale, we have things like from the Ovarian Cancer Association Consortium, where they did GWAS and other sequencing studies to identify low penetrance genes that were more common, that could increase the risk for ovarian cancer. So at that lower end, we have relative risks on the order of 1.3 for some of these low penetrance but more common genetic mutations. And at the other end of the spectrum, of course, we have BRCA1 and BRCA2, up to like a 44% increased risk. And in between, there's other genetic risks for ovarian cancer. So hereditary non-polyposis colorectal cancer, or HNPCC, and more broadly, Lynch syndrome increases risk more on the order of relative risk of 5 to 6. And then there's other things in there as well. So genetics clearly plays a part of these risk factors. Age, ovarian cancer increases with age. You know, lots of times when I give presentations, people are surprised to hear this, because we hear a lot about the early onset ovarian cancers. In large part, that's due to BRCA1 and BRCA2. And that is a big problem, and that's an important problem. But you know, BRCA1 and BRCA2 mutations, hereditary mutations, affect less than 0.5% of the general population. So it's not very common. Your garden variety ovarian cancer occurs postmenopausally. So the highest incidence is in the ages of 80 to 84. And the median age at ovarian cancer, epithelial ovarian cancer diagnosis, is 63. So half of the women are older than 63 when they get ovarian cancer. And I think a lot of people forget this, that this is really predominantly a disease of older women and postmenopausal women. Reproductive history. So pregnancies, the number of pregnancies, the timing of pregnancies, incomplete pregnancies, breastfeeding, tubal ligation, all of these things that might be tied to your reproductive history, those sorts of things are associated with a decreased risk for ovarian cancer. This is another success story. This is very, very well documented in both case control studies and cohort studies. And it can be a substantial reduction in risk depending on the particular variable that you're looking at. I've already mentioned hormone contraception. Again, depending on the aspect that you're looking at with hormone contraception, this can substantially reduce the risk for ovarian cancer. Because hormone contraception came really, at least combined oral contraceptives, came on the market in the 60s, those reductions that we're seeing that I showed at the very beginning of the talk in ovarian cancer incidence is really attributed to this hormone contraception, because it's changed in the time period that would affect the women who are now getting that ovarian cancer. Reproductive history hasn't changed that much. A few less children, but still women are still having children. So, you know, that's why these changes are really attributed for the most part to hormone contraception. I'm going to talk more about hormone contraception in a few minutes. Sorry. Obesity. Obesity increases the risk for ovarian cancer, but we didn't know that for a long time. I can remember giving talks in the early 2000s where the evidence at that time was that obesity was not related to ovarian cancer. And I'm going to show you why that is in a minute, and that has to do with the subtypes. Not clear what's going on with physical activity independent of obesity. There's some indication that this might reduce risk. But this is still an uncertain association at this point. And then we have the red wine, the baby powder, the green tea, and the NSAIDs, all that have a specific association with ovarian cancer, but are still somewhat controversial, although many of you have probably seen some of the news and the jury decisions about whether perineal powder caused some women's ovarian cancer. I'm not sure that that association is well established at this point. So this is kind of the 30,000 foot level. I am not going to, you know, go into all these, and I've not talked about every single risk factor. I've pulled out the ones that I thought you might have heard about. But I am going to talk about obesity a little bit more and hormone contraception a little bit more as it relates to reproductive history. So, hormone contraception. This is a fascinating history. Combined oral contraceptives, and what that means is it's just a combination of estrogen plus progestin, were developed in the late 40s and pretty much came on the market in the 60s. And I'm showing a bottle here on the right side of the screen, which was the first oral contraceptive that was given. It's not in these pretty blister packs that you see over here at the side that, that we get oral contraceptives in now. And one thing I would like to point out here is that these are combinations of estrogen plus progestin. So that 9.85 milligrams, that's a progestin, that's a specific type of progestin. And then the 150 micrograms of mestranol, that's an estrogen. Those are whopping doses. Those are really, really high doses. Now we give progestins like 0.1 milligram and 0.3 milligram. So these early oral contraceptives had whopping doses of estrogen and progestin. We also now have progestin-only pills. We have extended cycle pills, which just means it's not on a monthly cycle. It's usually on a 91-day cycle. There are patches, there are injections, there are implants, and then there are hormonal compounds that are released through devices, so such as the IUD and the vaginal rings. I am going to show you just some information about the combination oral contraceptives from my study, because, you know, when I did my study and for these women who used hormone contraception decades ago, remember the median age at ovarian cancer diagnosis is 63. No 63-year-old woman's on oral contraceptives, right? Or taking any sort of contraception. So this is decades ago that they took their contraception. And so really we only had the combination oral contraceptives that were widely used in our study. But before I get there, I just want to tell you that this is amazing how hormonal contraception has changed over time. I already indicated that there were whopping doses of estrogen and progestin before when they first came out. And then there was these sequential pills that gave straight estrogen, a huge dose of estrogen, which was really problematic for endometrial cancer to the degree that there was a spike in the SEER registry. I mean, you know, that shows how strong that was at that time. But we have monophasic pills, biphasic pills, triphasic pills, fourphasic pills, and 91-day pills. And these are all different dosages of estrogen and progestin. And these have changed over time, as have the patterns of use over time. And these other types of hormonal contraception have increased. For example, the injectables have increased from 5% in 1995 to 23% of women reporting use for this in 2006 to 2010. The patch use increased as well, as you can see here. Vaginal rings have only recently been used, but it was reportedly used by 6% of women in 2014. And then there's these long-acting reversible contraceptive methods. These are called LARCs. And this includes the IUD and the implants. And they've just been increasing over the years. And so we now have a cohort of women who are going through getting completely different hormonal contraception than they did 30, 40, or 30, 20 years ago. So we have no idea of how this is going to affect ovarian cancer risk. I told you I was going to tell you a little bit about this Oval BC study. We've been at this for a long time. Next year, we will have been at this for 20 years. I've been working with my colleagues in Canada to do a wonderful resource set up at this point, but it took us 20 years and, you know, a whole lot of funding to get to where we are. Can you see this okay? I just got a message that my internet connection was unstable. Is everything okay?
Yeah, it's looking, it's good. Your audio was just a little bit messed up for a second, but it's back to normal.
And I'm even wearing my headset.
All good, all good, all good.
Okay, thank you. This study took place from 2002 to 2012, so it was a 10-year study, and we got population-based invasive epithelial ovarian cancer cases and about 2,500 controls. 99% of them completely finished a comprehensive telephone interview or a questionnaire, and I'm talking comprehensive, 2.5 to 3 hours on the telephone to finish our questionnaire. This was above and beyond the call of duty. We got blood samples or saliva samples for 95% of them. As you already know, I've already told you this, we reviewed their histotypes so we could classify these by the contemporary histotypes. For 85% of the cases, sometimes while 99% of women or cases gave us permission to access their tissue, it wasn't always possible to get their tissue from, you know, around the provinces because these were province-based studies. But of those cases, we were actually able to get those into tissue microarrays, which is really nice and has helped us do all of this immunohistochemistry work. Okay, that's just the quick and dirty overview of the study. I'm going to jump into results. So this is the entire data set, and I'm just, this is combination oral contraception use. I just want to show you that we see like what everybody else sees, that ever use was associated with a 40% reduction in epithelial ovarian cancer. And then as you increased the duration of use, that you saw a nice trend in decreasing use to a 60% reduction if you had over 10 years. So I just wanted to show you that just to make it clear that we saw what everybody else sees. This is not new. This was not new at all. We completely expected that. So what we said was that given that, you know, we get this 40 to 50 to 60 reduction in ovarian cancer risk with combined oral contraceptive use, that we see this dose response with the duration of use, and that there's other data, I didn't show you this, but we see the same thing, that the magnitude of the reduction diminishes over time, but it doesn't go away for decades. Right, so it sticks around. We also know that I told you that reproductive factors are also associated with reduction in risk. So here for the full-term pregnancies, we knew that each full-term birth reduced ovarian cancer risk by 10 to 15%. So this has been estimated in meta-analyses. So we had this question, and this is really a timing question. So if we just took Paris women who are all benefiting from, you know, this reduction in risk with at least one full-term birth, if we looked at the timing of COC use before, after, or before and after the first term pregnancy, would we see a reduction in risk for epithelial ovarian cancer? So I'm going to show you a series of 3 tables here. They're all set up in the same way. This is, so in the columns, I have all the epithelial cancer subtypes. I have the serous high grade in the middle, and I have the endometrioid and the clear cell as one group. We did that because we did a sensitivity analysis and they seem to have the exact same risk. The low-grade serous and the mucinous, we had too few to be able to do this analysis by themselves. Okay, so what we see, if we look at their oral contraceptive use before and after a first full-term pregnancy, we see a substantial reduction in risk that looks pretty similar across all 3 groups, right? So it looks the same in everyone as it does in the subgroups. If we look at before the first full-term pregnancy, again, you know, we see a reduction in risk. Looks pretty similar across the 3 groups. But then if we look at if they only used oral contraceptives after the first full-term pregnancy, we see that at least for the point estimate, the reduction in risk has gone a little bit towards the null value. And in fact, none of those are significant anymore, which was interesting. So then we decided to break this up in the before, after, and before and after by duration. And so when we looked at before and after oral contraceptive use, before and after the first full-term pregnancy, we saw, again, pretty strong reductions in risk. Most, had a nice dose response for every additional year of use. So that looked good. And then when we looked at just exclusively before the first full-term pregnancy. Okay, so you got to wrap your head around this. So these are women who used oral contraceptives only before their very first pregnancy. They could have gone on to have 1 or more pregnancies. And now it's 20, 30 years later, and they've got a diagnosis of ovarian cancer, right? And we see that a substantial reduction in risk that was associated with the oral contraceptive use before the first full-term pregnancy in all the groups, and a very strong reduction for each additional year of use. And then when we look at after, if they used the oral contraceptives, exclusively after, again, we see this big attenuation of the effect. So what this was telling us, so I'm going back to this exclusively before the first full-term pregnancy, is that, this whole hypothesis about how oral contraceptives reduce the risk of ovarian cancer may not quite be right, because the whole idea is that oral contraceptives stop ovulation, and that by stopping ovulation, you reduce ovarian cancer risk. But this is a lasting impact for decades. And clearly these women kept ovulating because they had pregnancies. So it really indicates that maybe something else is going on. And in this way, we have to look at other cancers. And it has been very informative in the endometrial cancer literature, as well as the breast cancer literature. So women, what they see in breast cancer is that if you use oral contraceptives exclusively before your breast cancer, you actually have an increased risk, which is interesting, but you have a decreased risk for endometrial cancer. And in endometrial cancer, they didn't have this nice ovulation hypothesis. I mean, it was such a lovely hypothesis and it was such a nice story that everybody believed it. I believed it. I mean, it just fit, and it was such a nice story. But in endometrial cancer, what they show is that oral contraceptives actually trigger methylation, gene methylation, that literally shuts off some genes, and it appears to be a permanent shutoff. And so no one ever looked at this in ovarian cancer. No one ever looked at these alternate mechanisms of why this early use would you know, reduce risk so much. So that's the caveat in this. The other thing I promised I was going to tell you about was obesity. So I have pulled this from a paper from the Ovarian Cancer Association Consortium. So look at the numbers there. We're talking massive numbers, probably 10,000 women were in this study, and they could do this because they're a consortium. And they also could use these contemporary histotypes. This says serous, but this is really high-grade serous. I don't know why they mislabeled this in the paper. And then there's the mucinous endometrioid and the clear cell, which are the more rare types of epithelial ovarian cancer. And what I want to draw your attention to is that when you look at the serous, and remember, serous composes maybe 75, 80% of all epithelial ovarian cancers. And you see the reference group here is the normal weight women. And what you see is nada, right? You know, obesity is not associated with serous ovarian cancer, you know, risk. Well, because this was a major histotype, it just swamped everything else. Nobody could see the risk that you now see with mucinous, and I'll just start here at the reference group, but you can see a nice dose response. For the endometrioid, you can see a nice dose response. For the clear cell, you know, it bounces around a little bit, not as strong as a dose response, but still showing that pattern. So this is another success story. By having these, you know, by improving the misclassification in the different subtypes, getting these nice subtypes, we can really fine tune some of this risk factor information. Okay, so the challenges here are that, as I just said, I just made that statement, that these subtype classifications have helped us fine tune some of the risk factors, which is really great. The question here though is, are we going to redo all these analyses every time we come up with a new subtype classification? I suppose we are, and that's kind of my bread and butter, so maybe I shouldn't complain about that. But it does seem inefficient somehow. And I think the more we get this detailed information on risk that are associated with the, you know, some complex timing or some complex subgroup specific risk, this is going to help us figure out some long-term biologic mechanisms, because I am afraid with ovarian cancer, we all just bought into this. We stop ovulation, we prevent ovarian cancer. And I think it's more complicated than that. And we really do need to move on to the next level there. And then the final thing I want to say is that clearly, I hope I've shown that exposures and certainly modifiable risk factors, they change over calendar time. And we're looking at really old data. So that obesity data that I just showed you, that came from 11 case control studies, I can tell you that this data was collected in the 80s and the 90s. It's already 20 years old. That's not contemporary exposures, right? Or contemporary weight distributions or whatever it is. And you know, the NCI portfolio they did a grant portfolio to show how many cohort studies that they have that are really etiologic in nature. They had 16, 2 were phasing out, 2 were not US based. That doesn't bother me, but for some reason that bothered the NCI that they weren't US based. And then 3 were conversions from RCTs, which has its own issues, that, you know, a study was designed to be an RCT and then you turned it into a cohort study. So, and these study populations are really old, you know. They're mainly 75 years of age or older at this point. Of the ones that are still alive, 62% of these study populations in these cohorts are deceased. 75% are white. They don't show a good racial ethnic distribution. And it's decades old exposure information. And I don't know how we're going to address this. You know, the case control study is pretty much dead. That's how we have most of this information on ovarian cancer. That's pretty dead. but you can have a cohort study to do everything. The only cohort study that has really handled this well is the nurses cohort study that does repeated sampling and measuring of the women in that particular cohort. Okay, so thank you for your attention. I hope I haven't talked too long. Like I said, I left out a whole bunch of stuff. I can talk longer. But I really thank you for your attention and this opportunity to talk to you. And I am really happy to answer any questions. And I think I saw some comments in the chat.
Yes, thank you, Dr. Cook, very much. Raj, did you have a comment first, and then we can jump into some of the chat questions?
How are you, Linda? Good to see you.
I'm very good. Nice to see you, Raj.
Yeah, so in your talk, there's something which relates to what I do, green tea, which I'm drinking now, and red wine or another alcohol in the evening. So those things relate to me.
But you're not going to get ovarian cancer, Raj.
No. And they are my research interests as well. And a lot of people on this call may know that I work or I have worked with green tea. I work with resveratrol, which is red wine,
Right.
and I work with NSAIDs. Even currently, I have a couple of grants on those things. So the question I want to ask you is that based on your slide showing a decreased risk factor with these three things, yes, has someone done any lab research to connect it, or is this a gap to be addressed, or it's not a big deal?
So specifically for which exposure?
Red wine is good, green tea is good, and said, I mean, all these things have been worked a lot for chemo prevention. That's why I'm asking.
Yeah. You know, I do think that there's a lot of research that is going on with them. And I have to say, I find the laboratory evidence more convincing than I find the population-based data. And again, Raj, I don't know, again, if this is a timing thing. We're looking at, you know, old forms of, you know, some of these drugs, or we are looking at times when people didn't drink so much. You know, I did do an analysis of the alcohol consumption and ovarian cancer risk off of this study. And of course it was in Canada. So I looked into the trends of, you know, how people are drinking, and it's unbelievable how both white and red wine have just increased substantially, right? There is definitely a cohort effect there. And it could be as well for things like green tea. It could be as well for things like NSAID use, right? Like maybe back in the 60s and 70s, people weren't taking as much ibuprofen or whatever it is as they are now. So while I find the laboratory data pretty convincing, and you're right, there is a lot of it. And I think some of it's very specific to ovarian cancer. It's just not showing up in the population data yet. So we can't even say what the risk is, right? And it's not showing up consistently. And I think it's the problem with the data that we have. We have old data.
Thanks.
Dr. Cook, just a couple of questions. One from Dr. Heideford here. Couldn't reduced ovulation over your lifetime due to oral contraceptive use still be a contributing factor, although perhaps not the only factor?
Certainly. And I think it might be most important for the mucinous tumors. But it could play a role. And I didn't mean to imply that it couldn't play a role. I'm just saying that was such a lovely hypothesis. We could all see it. We could all understand it. We could all, and people, even people who aren't in the ovarian cancer field, they all know this, you know, like it was easy to understand, and people, you know, were keyed into it. But I think we were a little too quick to attribute everything to that. But no, I do think it plays a role for sure.
Very good. I have a question that came in actually in advance on the internet. Do you think that we'll see a reduction in ovarian cancer now that the talc is sort of off the market?
Well, powder is not off the market. there's still a lot of powder on the market, and so there could be a decrease in terms of the way that women are using it. You know, there's a real so I also years ago in my postdoc actually did an analysis of peritoneal or perineal talc use and ovarian cancer risk. At that time we didn't have the subtypes, so this is all epithelial ovarian cancer. And, you know, I did see an increase in risk, but there were funny things like there was no dose response. And, you know, there were just, all of a sudden it would be nothing and then it would jump up and then it would go down to nothing. It would, you know, when you were trying to see like a dose response and, you know, the plausibility of this, right? You know, talc is a pretty inert substance. And so then the biologic plausibility always bothered me with respect to ovarian cancer. The idea was that in the early days is that it has asbestos contamination. So, you know, I think everybody's heard the story about the, during World War II, the women who were painting the, radioactive dials, you know, so that they could be seen at night. That paint had asbestos in them, right? And so, and they'd lick them with their mouths. And, you know, they were like asbestos fibers that you would think about in the lung, and they worked their way into the circulatory system. And for whatever reason, they honed in the ovary. So when this powder thing first came out, they attributed it to contamination by asbestos. But, you know, I also looked into that, and the manufacturers of powder are very careful, right? And of course they are, right? I mean, they don't want to be sued for using their products. And asbestos formations and what they're using for, you know, powder and talc are very, very different. And it would be really, really surprising if they made the mistake of mixing the two. Do you see what I mean? So I don't know what I think about that. I really don't. I know that there's been a lot of press about that lately, but I am not convinced that that is a strong risk factor for ovarian cancer.
One last question before we let you go that also came in before our meeting today, and that is asking about the potential value of liquid biopsy or blood-based tests as a screening test for ovarian cancer.
Yeah, I think that's perfect. For any internal cancer, those you know, liquid-based biopsies are a godsend, right? You know, we can figure out, you know, melanoma, and to some degree we can figure out breast cancers because we can access the tissue. But for these internal organ tissues, it's really hard. So I think that would be fantastic. I know that a lot of people are working on it. I haven't seen any evidence that can be used on a population basis yet, but I think it has great promise, great promise.
Well, thank you very much. I apologize we can't get to all the questions, but we've probably taken enough of your time. I appreciate your passion and your presentation today, and go Hawks.
Yeah, okay. Nobody's going to know what that means, Jamie.
I know, but I knew you would.
Okay, thank you again for having me. I very much enjoyed this.
Thanks everyone for joining, and hope to see you next month for Dr. Carter Harris's presentation.
Thanks, Linda.